Hi everyone! Today we'll be talking about pancreatic cancer. This project was put together by Danielle Cisterino, Megan Cooper, Rebecca March, and Alyssa Moss. First, we would like to start off with some quick facts about pancreatic cancer. Currently, it is the fourth leading cause of cancer deaths in the United States. For men, it's the 8th most common, and for women, it's the 9th most common. It represents about 3% of new cancer diagnoses in the United States, and it is commonly associated with a poor prognosis. A lot of times when people are diagnosed with pancreatic cancer, they hear this as a death sentence. For 85 to 90% of the sufferers, by the time they are diagnosed, it is already metastatic and/or it's inoperable. And only 6% of cases are able to reach that 5-year survival milestone. So let's get started with the organ itself. The pancreas is located in the upper abdomen, quite deep. It's behind the stomach and a little more towards the left-hand side. It is also near the liver, spleen, and small intestine. The pancreas plays a couple of roles. It plays a part in digestion, where it serves an exocrine function. An exocrine function meaning it secretes hormones or chemicals into a system of ducts, where it gets to its target. The pancreas is responsible for secreting the powerful digestive enzymes that break down the foods that we eat. Specifically, the pancreas is where trypsin is developed, where it breaks down proteins. Lipase is also produced to break down fats, and amylase, which breaks down the carbohydrates. All of these enzymes stem from the various ducts throughout the pancreas, are then mixed with bile from the liver in a part of the organ called the ampulla of Vater, and it is then released into the duodenum, which is the upper small intestine where it connects to the stomach. And this is where a lot of digestion occurs. The other role it plays, it has an endocrine function. Endocrine function meaning it releases the hormones directly into the bloodstream, and this is when it regulates the blood sugar levels. In the pancreas, there are groups of cells that create what's called islets of Langerhans. In humans, our pancreas has 1 to 2 million of these. In these islets of Langerhans, this is where both insulin and glucagon are produced that are then secreted directly into the bloodstream in order to regulate blood sugar levels. Insulin serves an anabolic purpose. It's going to increase the storage of glucose, amino acids, and fatty acids. When you have an excess of insulin, that's when hypoglycemia occurs, and a deficiency of insulin causes diabetes. Glucagon, in contrast, serves a catabolic purpose, and it moves these glucose, amino acids, and fatty acids from the storage point into the blood. When you have an excess of glucagon, this is what's going to exacerbate diabetes, and when you have a deficiency of glucagon, that's when you're going to also have hypoglycemia. So as we can see, the pancreas is very important. There are a few organs that one can live without, but the pancreas is definitely not one of them. When something goes wrong within the pancreas, it can cause severe detrimental health effects. All right, so let's get into the actual pancreatic cancers. Lining the various ducts inside of the pancreas, there are specialized epithelial cells. And these are the ones associated with the digestive or exocrine functions of the pancreas. And most, so about 99% of pancreatic cancers are going to be adenocarcinomas or carcinoma of the pancreas, arising from these specialized epithelial cells, again, that line the pancreatic ducts. So the cancers will start here at these cells and ultimately can spread and lead to invasive cancer. The remaining types of pancreatic cancers can stem from the endocrine functions of the pancreas. This is a lot more rare. It's only about 1 to 2% of pancreatic cancers. and these stem from the specialized cells that are within the islets of Langerhans that I spoke about on the previous slide that are responsible for insulin and glucagon in regulating blood sugar. Most of these are going to be beta cell tumors, which stem from the beta cells that are in the islets of Langerhans. 60 to 70% of cells making up the islets of Langerhans are these beta cells, and they're located at the center. And these beta cells are specifically responsible for the production of insulin alone. So because of this, these can sometimes be called insulinomas, and an indicator of these would be low blood sugar or hypoglycemia. Most tumors that start here from these islets of Langerhans are benign, so about 90% of these, so less than 10% are actually malignant. These can develop when there is epigenetic suppression of several tumor suppressor genes or germline and somatic mutations. So now we will talk about some genetic components that relate to pancreatic cancer. There are 4 specific genes that are either inactive, mutated, or missing from patients with pancreatic cancer. The first is the gene KRAS, which codes for a certain protein to help regulate cell proliferation. This gene is either inactive or mutated with regard to about 60 to 75% of pancreatic cancers. P16, P53, and SM84 are all tumor-suppressing genes. P16 in particular is missing from about 95% of people with pancreatic cancer. P53 is inactive or mutated in 50 to 70% of tumors. And SM84 is missing from about 55% of tumors. And so with this, these can all allow cancerous cells to grow and to grow unchecked. Up to 16% of pancreatic cancers may be inherited. Genes relating to this are STK11, BRCA2, P16 or CDKN2A, PALB2, HMLH1 and MSH2, ATM, and PRSS1. Germline mutations of any of these greatly increases the risk of developing pancreatic cancer. Specifically, a mutation of the STK11 gene, also known as Peutz-Jeghers syndrome, increases one's risk by 132-fold, which is quite a bit. So people with this syndrome have a greatly higher risk of developing pancreatic cancer in their lifetime. BRCA2 mutations are also associated with increased risk of breast and ovarian cancers. And getting to PRSS1 gene, mutations of this gene are associated with the familial pancreatic cancers. Next, we're going to get just a little bit into staging. From this image here, you can see it outlines stages 1 through 4 of pancreatic cancer, where stage 1, you can see that they have a couple tumors indicated they're just in the pancreas organ alone. Moving up to stage 2, they have indicated that the cancer has now spread regionally to some lymph nodes. And getting to stage 3, it's spread via some arteries, and it's just spreading to other areas of the body. Where stage 4, it has metastasized, and they've indicated that this liver organ now has tumors on it as well. Most cases are diagnosed after 50 years old, with the peak age range of being 65 to 70 years old. 60 to 70% of pancreatic cancers are located at the head of the pancreas, with the remaining 30 to 40% at the body or the tail of the organ. These pancreatic tumors are difficult to feel from outside of your body because your pancreas is located really deep in your abdomen, underneath your stomach. So it's really hard to feel, and there's really no valid biomarkers of this disease, so this allows for pancreatic cancer to go undiagnosed for many, many years, allowing the tumor to grow and eventually metastasizing before anyone even knows that they have it, thus having a pretty low survival rate. At this time, I want to take a minute or two to talk about Jack Andraka. He was a student at the North County High School in Glen Burnie, Maryland. When he was 15 years old in the spring of 2011, he had a close family friend die of pancreatic cancer. He learned of the late diagnosis and low survival rate of pancreatic cancer and decided that he wanted to design an early detection tool that was both inexpensive and decently accurate. So on his own, he did some studying and learned about a protein called mesothelin, and it actually is a biomarker for many other cancers when it is overexpressed in human blood. Overexpression of mesothelin is also occurs in early stages of pancreatic cancer. In addition to this, he was also fascinated by the idea of carbon nanotubes. Carbon nanotubes are cylinders of carbon molecules that are only 1/50,000th the diameter of a human hair. And these nanotubes have lots of useful properties in the science world, both mechanical and electrical. While in biology class his freshman year, they were studying antibodies, and he came up with an idea to incorporate mesothelin-specific antibodies into these carbon nanotubes. These complexes would only react to mesothelin in the blood when the mesothelin proteins attached to the antibodies. Once this happens, the gaps between the carbon nanotubes would widen, thus weakening the electrical conductivity. And this can be detected on an ohm meter. So Jack wrote a 30-page research proposal and sent it to a bunch of people and got a lot of rejections. But he did get a maybe out of a pathologist from Johns Hopkins University named Anirban Maitra. This pathologist invited Jack to work in his lab, and Jack took him up on the offer. He went almost every day for 7 months, his mom driving him there after school. The following January, so January of 2012, all of his lengthy hard work started to pay off. He had filter paper, just common filter paper from the grocery store, that was dip coated, and he used these test strips and he hooked them up to the ohm meter, which he bought for $50 at just a local Home Depot. And they successfully measured the mesothelin in the blood of transgenic mice with pancreatic tumors. And it also measured the mesothelin in the blood of a few human samples. So he knows that there's a lot more work to do, but his idea won him the grand prize at the 2012 Intel International Science and Engineering Fair, which earned him $75,000 in scholarships. After that, he appeared on ABC World News Tonight, delivered 6 TED Talks, he's appeared on many TV specials, and continues to impress everyone in science.
Pancreatic cancer is usually fatal. The survival rates 1 year after diagnosis is around 20%, so this is very low. And also without treatment, a person who is diagnosed with pancreatic cancer, there is a 3 to 5 month survival. Also based on the 2015 estimates from the American Cancer Society, there are approximately 49,000 new cases that are likely to show up over the course of this year, and 40,500 people are likely to die from this disease, and the average risk is 1 in 67. This slide shows the percentage of cases by stage and the 5-year survival rate of pancreatic cancer, also by certain stages. So for the 5-year survival rate, as the cancer becomes more spread from a localized to a distant stage, the survival rate decreases significantly. And for the percentage of cases by stage, the graph shows that a very small percent of pancreatic cancer cases are found at a localized stage rather than a distant stage, and this is due to the fact that symptoms are more developed at a distant stage, at a more spread or a distant stage, rather than the localized stage where symptoms are not seen. This graph shows the incidence and mortality rates of pancreatic cancer by gender in the United States. And as you can see, the incidence for males and mortality for males is slightly greater than for females. And the trend for both males and females seems to be becoming more narrower. This graph is just a quick representation of, again, the pancreatic cancer incidence and mortality rates in the United States. And this is just to show that African American males are the group of people that have the highest incident rate and mortality rate in the United States. And now on to the signs and symptoms for pancreatic cancer. Well, there are actually two types of pancreatic cancers, exocrine and endocrine, and they have different signs and symptoms. For exocrine pancreatic cancers, jaundice, which is yellowing of the skin and eyes, and some other signs that come along with jaundice are dark skin, light-colored stools, itchy skin. Some more symptoms related to exocrine pancreatic cancers are having abdominal or back pain, weight loss or decreased appetite, digestive problems, which are a prominent problem as seen for exocrine pancreatic cancers, having pale, greasy stools, nausea, and vomiting. Some other symptoms of exocrine pancreatic cancer are gallbladder enlargements, blood clots, especially in the lower leg, fatty tissue abnormalities, and diabetes, but this is a very rare symptom for exocrine pancreatic cancers. The signs and symptoms for endocrine pancreatic cancers are variable based on the type of tumor that is formed from these cells. For example, gastrinomas produce excess amount of gastrin, and they produce symptoms of stomach pain, nausea, appetite loss, and even ulcers. And these ulcers, if they become severe enough, the person could have stools that are more tar-like due to bleeding happening. For insulinomas, some symptoms of this are weakness, confusion, rapid heartbeat. And also for endocrine pancreatic cancers, they can produce symptoms that are very similar to the exocrine pancreatic cancers, such as the non-functioning neuroendocrine tumors that can be formed from these types of cells. These tumors can cause jaundice, stomach pain, and weight loss, which these three symptoms are very similar to exocrine pancreatic cancers. This is just a summary of the signs and symptoms of pancreatic cancer, particularly for the exocrine pancreatic cancer, since these are more common than endocrine pancreatic cancers. I'm not going to go through all of them as they have been stated in the slides previously, but something interesting to note is that pancreatic cancer can be misdiagnosed for gallstones, gastritis, irritable bowel syndrome. So it's very important to pay attention to if you're having such symptoms as you may actually have pancreatic cancer rather than a common misdiagnosis. So for major risk factors, there are quite a few risk factors for pancreatic cancer. Smoking, alcohol consumption, having a diet high in dietary fat, particularly related to animal sources like red meat and dairy. Obesity contributes to pancreatic cancer risk. Chronic pancreatitis, which is inflammation of the pancreas, and pancreatitis is associated to alcohol abuse. And for the pancreas is commonly inflamed quite frequently. This could eventually lead to pancreatic cancer. Having a family history of pancreatic cancer increases your risk of this cancer, and also inheriting any type of genetic mutation. Having diabetes and stomach problems can also increase your risk of this cancer. Some other risk factors associated to pancreatic cancer are age. So as you get older, your chances of getting this cancer do increase. For gender, men are more likely to develop this cancer than women. And for race, African Americans are the group of people that are at a higher risk of developing this cancer, and the reason for this is unknown, but it has been suggested that genetics and diet play a role in the risk of developing this cancer.
There are 5 types of standard treatment: surgery, radiation therapy, chemotherapy, chemoradiation therapy, and targeted therapy. When the tumor can be removed, there are 3 procedures that can be done. The Whipple procedure: the head of the pancreas is removed, the gallbladder, part of the stomach, part of the small intestine, and the bile duct. Enough of the pancreas is left to produce digestive juices and insulin. Total pancreectomy is removal of the whole pancreas, part of the stomach, part of the small intestine, the common bile duct, the gallbladder, the spleen, and the nearby lymph nodes. A distal pancreectomy: the whole body and tail of the pancreas are removed, and usually the spleen is removed also. When the cancer has spread and the tumor cannot be removed, there are 3 procedures that can be performed. The surgical biliary bypass can be performed when cancer is blocking the small intestine and bile is building up in the gallbladder. The gallbladder or bile duct will be cut and sewn to the small intestine to create a new pathway around the blocked area. An endoscopic stent may be put in if the tumor is blocking the bile duct, and the stent may be put in to drain the bile that has built up in the area. The stent is placed through a catheter that drains to the outside of the body, or the stent may go through or around the blocked area and drain the bile into a small intestine. The gastric bypass may be performed if the tumor is blocking the flow of food from the stomach. The stomach may be sewn directly to the small intestine so that the patient can continue to eat normally. Another type of treatment is radiation therapy. It is a cancer treatment that uses high energy X-rays or other types of radiation to kill cancer cells or keep them from growing. Another type of treatment is chemotherapy. There are 20 approved chemotherapy drugs for pancreatic cancer by the FDA and 4 drug combinations, which are not necessarily approved but are widely used. In October of this year, Onivyde, in a combination with chemotherapy treatments 5-fluorouracil and levocorvin, was approved by the FDA, which aims to treat metastatic pancreatic cancer in patients who have failed to respond to chemotherapy drug gemcitabine. Onivyde carries a black box warning, which is the FDA's most severe and restrictive warning. It has severe risks of diarrhea and low white blood cell count. Another type of therapy is chemoradiation therapy, which is combined chemotherapy and radiation. Another type of treatment is targeted therapy. Targeted therapy uses drugs or other substances to identify and attack specific cancer cells without harming normal cells. Tyrosine kinase inhibitors block signals needed for tumors to grow. An example used in treating pancreatic cancer is Ernolib. There are treatments for pain also. Medicine can be injected into the area around the affected nerves or cut the nerves to block the feeling of pain. There's also a new type of treatment being tested called biologic therapy, which uses patients' immune system to fight cancer. Patients may also want to participate in clinical trials, and follow-up tests may be needed. In the 1970s, tobacco use was found to cause pancreatic cancer. Several studies found that tobacco use, especially cigarette smoking, is a major cause of pancreatic cancer. Smoking cessation became the primary tool for reducing the risk of the disease. A systematic review done by Widener and Hoffman found that prospective and retrospective studies have found a correlation between smoking of cigarettes, cigars, and pipes and the cancer of the pancreas. They have also found that 10 to 15 years after giving up smoking, the ex-smoker faces the same risk of developing cancer of the pancreas. Their goal was to prevent young people from starting smoking and to convince smokers to quit smoking. In 1981, chemotherapy plus radiation effectiveness was studied for patients who cannot be treated surgically. A randomized comparison of high-dose radiation alone, moderate-dose radiation with 5-fluorouracil, and high-dose radiation with 5-fluorouracil was studied by Mortal, Friedeck, and Hahn. There were 194 patients included in the study. It was found that 40% of patients treated with the combined regimens were still living at 1 year compared with 10% treated with radiation only. In 1985, chemotherapy plus radiation as adjuvant therapy was studied. A prospective randomized study was done by Kaiser and Ellenberg. 22 patients were randomized to no adjuvant treatment and 21 to combined therapy. It was found that 4 patients, 3 in the treated and 1 in the control group, had survived 5 years or longer following surgery. The median survival for the treatment group was significantly longer than those observed for the control group. In the 1990s, new imaging techniques helped doctors assess and identify which patients needed more aggressive care. In a 1990 study by Snady, Bruckner, and Siegel, there were 3 reliable criteria selected for the identification of tumor invasion of major veins. Arterial involvement was identified by alteration of vessel course and caliber. All 7 patients with arterial involvement also had venous involvement. These signs provide reliable criteria for endoscopic ultrasonographic definition of unresectable tumors in patients with a pancreatic neoplasm that appears to be resectable on standard radiological tests. In 1997, Burris, Moore, and Anderson studied the improvements in survival and clinical benefit with gemcitabine as first-line therapy for patients with newly diagnosed advanced pancreatic cancer. The study was a randomized clinical trial involving 126 patients with advanced symptomatic pancreatic cancer. The study found that gemcitabine is more effective than 5-fluorouracil in alleviation of some disease-related symptoms in patients with advanced symptomatic pancreatic cancer. Gemcitabine also has a modest survival advantage over treatment with 5-fluorouracil. In 2005, the first targeted drug was approved for pancreatic cancer. A phase 3 clinical trial was done by Moore, Goldstein, and Hem that included 569 patients. The study demonstrated statistically significant improved survival in advanced pancreatic cancer by adding erlotinib to gemcitabine. The recommended dose of erlotinib with gemcitabine for this indication is 100 milligrams. In 2008, a major study mapped the pancreatic cancer genome. In 2008, Jones, Zhang, and Parsons performed a comprehensive genetic analysis on the pancreatic cancer genome. The data indicated that genetically altered core pathways and regulatory processes only become evident once the coding regions of the genome are analyzed in depth. Dysregulation of the core pathways and processes through mutations can explain the major features of pancreatic tumorigenesis. In 2013, a new first-line therapy extends survival for advanced pancreatic cancer patients. A phase 3 clinical trial was done in 2013 by Von Hoff, Irvin, and Arena on 861 patients. It was found in patients with metastatic pancreatic cancer, nab-paclitaxel plus gemcitabine significantly improved overall survival, progression-free survival, and response rate, but rates of peripheral neuropathy and myelosuppression were increased. There are many important information sources for people and family members that have pancreatic cancer. The National Cancer Institute offers a wide variety of accurate, free, up-to-date information about pancreatic cancer to patients, families, and the public. They also have resources to help find clinical trials. Confronting Pancreatic Cancer provides impartial, understandable, practical information about pancreatic cancer. They also provide free information and counseling on a phone line and a phone service to contact a fellow survivor. The Pancreatic Cancer Action Network, Incorporated, has a patient and liaison services, also known as PALS program, which offers information about pancreatic cancer, treatment options, diet and nutrition, specialists, and clinical trials specific to pancreatic cancer, and more. They have a survivor and caregiver network through which newly diagnosed people and families are matched with volunteer survivors and caregivers. The Hirschberg Foundation for Pancreatic Cancer Research provides a variety of information, resources, and support to pancreatic cancer patients and families, including referrals for treatment facilities, second opinions, and doctors across the U.S. The Luxgarden Foundation for Pancreatic Cancer Research has a free patient handbook called Understanding Pancreatic Cancer, newsletters, and a free quarterly Ask an Expert patient information series, which includes updates on topics of interest to those with pancreatic cancer.
So as far as public health issues are concerned for pancreatic cancer, the global epidemiology in 2012, 337,892 cases were diagnosed of pancreatic cancer, causing 330,391 deaths. So obviously, as previously mentioned, pancreatic cancer is highly fatal, and that really is probably the biggest public health issue concerning this form of cancer. Pancreatic cancer causes about 3.7% of all cancer deaths. So even though it is a rare cancer form, it's highly fatal, which is what makes it of such great concern. So a couple of things that I'll kind of focus on here is talking about a little bit about the rates, but also talking about the fact that there really is very little in the way of prevention and detection. So one of the other things that's kind of worth noting about pancreatic cancer is that it is more diagnosed, or there are more cases in developed countries, especially affluent developed countries, which may be of some interest as far as the epidemiology or the causes of it. what are things that are going on in affluent, developed countries that are causing higher cases to be diagnosed. So for example, in the U.S., it's in the top 5 causes of death, pancreatic cancer is, but in other underdeveloped countries, it's in the top 10. So that's kind of a drastic difference there. As far as smoking is concerned, it is well known that chronic smoking increases the risk by about 74% versus a non-smoker. So, your chances of getting pancreatic cancer are 74% higher if you're a chronic smoker as compared to somebody who doesn't smoke at all. And the World Health Organization states that it's estimated 1 in 3 people worldwide smoke. So if we know that pancreatic cancer and smoking are linked, and we know that 1 in 3 people smoke in the world, then the chances are this is going to be a great concern as far as a public health issue. So this next slide really just addresses the high fatality rates associated with pancreatic cancer. And this table is provided from the American Cancer Society. So as you can see, when you start at the top, look in the left-hand column, it just breaks apart the different stages or levels of diagnosis. Obviously, stage 4 is the last stage, and it's the most serious stage. And if you look to that stage, you see that only 1% of folks are surviving a year out of diagnosis. So the other kind of conundrum about this is that pancreatic cancer is so hard to diagnose early on. So if you think about it in those terms, how do we catch it earlier? Because that really is the way that we're going to save lives. We have to figure out ways to, catch this form of cancer before it gets to a stage 4, which is what's difficult about this because of where the pancreas is situated in the body. It's deeply embedded in the core, and so it's rather difficult to diagnose until it's, for lack of a better term, before it's almost too late. And it's really dismal to think that only 1% of people are surviving a year after diagnosis. So a lot of what we'll talk about in the next slide really is just prevention and things that we can do to detect this earlier on. So really, the focus for pancreatic cancer and reducing the rates of this and increasing the survival rates would be to invest in prevention and earlier detection. So as far as prevention is concerned, smoking is a clear association. We do know that. But other techniques of prevention really are less known, and it's even though it's suspected and there is research to back the fact that eating a diet that is rich in whole grains and vegetables and just maintaining a healthy weight, there's research to back all of that, but there really still needs to be more research to draw clear associations between what can prevent this form of cancer. So we know that if people really want to prevent this, they definitely need to not smoke, avoid smoking completely. There is some association between the amount that people smoke and their chances. So for example, a person who smokes 2 packs a day or upwards of that, they are going to have 5 times greater risk than somebody who only smokes, maybe 1 to 9 cigarettes a day. But at any rate, we know that the less a person smokes, the less their chances are, but the best way to just avoid increasing your chances at all or having the lowest chances are just to avoid smoking completely. Limiting alcohol, there has been a lot of research that talks about chronic alcoholism and the links between that. So limiting alcohol consumption, especially not binge drinking or drinking heavily, is a good prevention technique. Maintaining a healthy weight. Avoiding type 2 diabetes is huge. That's also, there's links that have been studied between that. So basically, just having a healthy lifestyle is prevention in and of itself, not unlike other forms of cancer. Exercising, keeping yourself at a healthy weight, having a very healthy diet, those sorts of things are really where most of the prevention is centered. As far as detection is concerned, this is problematic because, again, this is where we find we don't have very good detection methods in place. Some of the different things that are used to detect pancreatic cancer are physical exams. A screening could be done by a physician where they're going to actually just palpate the abdomen. And of course, that's problematic because there's many other organs in the abdomen, so they may not detect a mass as readily that way. Other ways to detect this are some diagnostic screenings like X-rays, CAT scans, MRIs. Needle biopsies are done, and they can be guided by MRIs or CTs, or even ultrasounds. But the problem here is that pancreatic cancer, by the time these forms catch it, it's already become a mass. And we know that pancreatic cancer develops over many, many years. It's not something that just happens in a short term or very fast. So what we really need to focus on and what really needs to happen is more research centered around finding out earlier detection methods and improving the diagnostics. Some of that, of course, involves figuring out the genetics behind it and different genetic mutations that will help us to better predict a person's risk.